We'll get started. So today we have a guest lecturer from our neighbor LPCH, Dr. Jamie Rosa, who works as an allergist and treats both adult as well as pediatric patients. We've heard great things and we're looking forward to, I love this title, so we'd like to hear a little bit about what he has to say today. So thank you.
Yeah, sure. My name is Jamie. I'm a third year and allergy fellow, and I'm doing my last year here. We actually cover adult and pediatric allergy, so you'll see us on both sides. And a couple of months ago, I was talking to Jane Wong, and she had some pretty basic question about allergic rhinitis, and I was talking to her about that. And it was evident to both of us that in terms of people working in ENT, their understanding of allergy might be somewhat lacking in the sense that even some of the fundamentals or basics of allergy, she wasn't really truly knowledgeable of. So she wanted me to come by and talk to you guys about allergic rhinitis, and a couple of, I think 2 weeks ago, Jen also wanted me to talk about the latest therapies of allergic rhinitis. So in this talk, I'll kind of try to go through the whole spectrum. And when I first started fellowship, my program director, Sean McGee, he really set the tone for how to approach allergic rhinitis to me. We had a very complicated patient with chronic rhinosinusitis, and he basically asked me the question, how come there's a cardiologist, but there's a cardiothoracic surgeon, and there is a neurologist and a neurosurgeon, but there is no rhinologist and rhinothoracic surgeon. And I couldn't answer his question. And he basically said, from my perspective, you as allergist is the rhinologist and the ENT surgeons are the rhinologic surgeons. And it really changed the way that I view allergic rhinitis since then, in that it's really a disorder that should be tackled from both sides, both the surgical side and the pharmacotherapy and immunologic side. So I'm really happy to come and tell you more about allergic rhinitis from the allergist's point of view. And I'm very grateful for Dr. Nayak and Dr. Seidel for letting me hang out with them for a couple of weeks to learn rhinoscopy and what they do, because I feel like it's important for us to learn what surgeons do for allergic rhinitis as well. So I have no conflict of interest to disclose. I'm supported by a NIH T32 training grant, but other than that, it's not really a disclosure, and I'm not going to say anything related to NIH today. So here are some of the learning objectives for today. Basically doing some basic things like defining and classifying rhinitis. We'll talk about diagnosis of allergic rhinitis and non-allergic rhinitis, and the treatment and the latest research for allergic rhinitis.
Somebody dim the lights, please.
So in preparing this talk, how did I come up with my source of information? You guys probably want to know that. Did I pull it out from the sky? Or did I get it from some ancient text back in the days? And you will see it's going to be a combination of both. And you'll see why that's the case soon. So most of the information that I got from this talk is from our practice parameters. That it's a joint task force. It's created by the joint task force from the American Academy of Allergy, Asthma, and Immunology, as well as the American College of Allergy, Asthma, and Immunology. And so they basically came together in 2008 and came out with these practice parameters. And this was from 2008, so kind of ancient text. Our organization likes to come up with new practice parameters every about 10 years or so. And so it's about time that it's due. For example, this practice parameters didn't talk about sublingual tablets. So I think the next update will probably focus on that. That came out last year. And so I'll talk about that as well. And the way that this practice parameter or guidelines are structured is that it really gave recommendations based on evidence. And so the lower number is the highest level of evidence, and the higher numbers are the lowest level of evidence. So for 1A, for example, it's based on meta-analysis of large randomized controlled trials, whereas number 4 is based on expert opinions. And so from that, they came up with strength of recommendations, A being the highest and D being the lowest. So with that, I think the first thing to do is use this parameter and try to define rhinitis. And so the definition of rhinitis is basically one or more of the following symptoms: nasal congestion, rhinorrhea, sneezing, and itching. Strength of recommendation, D. Wow, I'm not doing so great already. You guys probably don't trust anything I say anymore. I mean, I can't even define rhinitis with a high level of confidence. How can you guys believe me? And so that's basically our field in allergy, is that you will see a lot of variability in terms of the way that we practice our approach to allergic rhinitis. And it's not really only because some of us don't really follow the guidelines. It's that even though there are guidelines, they're not very strong. And so even when in this talk itself, a lot of what I say will come from my own clinical experience and anecdotal teaching that has been passed on to me by my allergy attendings. So the way that we classify rhinitis, at least for today, we'll break it down into allergic versus non-allergic. And everything on the right side of allergic is, think of that as non-allergic. And there's so much to talk about in the allergic side of things that I won't have time to talk about non-allergic rhinitis really, but if you guys are interested in me talking about the different subtypes of non-allergic rhinitis, I'm happy to do that in the future. So in terms of the background of allergic rhinitis, there are a lot of people who have allergic rhinitis. So someone like Dr. Nayak, who sees 50 patients in half a day, for example, he probably has 5 to 15 patients who have allergic rhinitis, which to me is a lot. And in the pediatric side, like Doug Seidel and Peter Fortai, they probably see, they see even more patients with allergic rhinitis. So a lot of patients that you see will have this disorder. So keep that in mind when you're seeing your patients. As you probably know, rhinitis is a significant cause of lost work and school days. I am doing a little bit better. These strength of recommendations are C. So that's a good sign. And basically differentiate between allergic rhinitis and non-allergic rhinitis is a strong personal and family history of atopy. So if there's atopic condition, if we obtain IgE and it's very high, if there's positive skin testing or specific IgE, that really points you towards allergic rhinitis versus non-allergic rhinitis. And for reasons that I don't think anybody knows, higher socio-economic class is also associated with allergic rhinitis. In terms of the non-allergic rhinitis, it's basically rhinitis that you can't find specific IgE against, and we'll talk a little bit more about differentiating between the two in a little bit. And so here are the different subtypes of non-allergic rhinitis. There is really a lot, and so like I said, I won't be able to talk about it today, but just so you know that there are a lot of things that can cause non-allergic rhinitis. And so, as I was mentioning before, the best way to differentiate allergic rhinitis and non-allergic rhinitis is really a personal and family history of allergies. And so under family history, for example, you see that if there are first-degree relatives who have eczema, food allergies, asthma, then that really points you more towards allergic rhinitis. And patients with allergic rhinitis tend to have an earlier onset than non-allergic rhinitis. In terms of triggers, it's really hard to tell because, for example, pollen, they travel miles and miles and miles away, so you can't really ask a patient, oh, are you exposed to tree pollens or grass pollens? But someone who comes to my clinic and says, every time I walk in a room and a cat is there, my nose starts going crazy, I'm pretty confident that when I skin test them, their cat skin test is going to be pretty positive. And so there are certain indoor allergen triggers that you can ask your patients and feel pretty confident about. And so there is no strict definition for making the diagnosis of allergic rhinitis. There's no criteria like, if a patient fulfills 5 symptoms out of 8 symptoms, then they have allergic rhinitis. It's really a clinical diagnosis based on your gut feeling, but the more features that they have on the left side, the more likely that you are right, that you're making the right diagnosis of allergic rhinitis. Again, a huge difference between allergic rhinitis and non-allergic rhinitis is that you're able to find specific IgE on allergic rhinitis, but not on non-allergic rhinitis. And then, to complicate things, there's something called, and I forgot to mention that there's also mixed rhinitis, so you can have allergic rhinitis and non-allergic rhinitis coming together. And actually, it's quite common in allergic rhinitis to have also non-allergic rhinitis. And so a patient who is skin test positive to tree pollens, grass pollens, and you ask them, what about when you travel and there's pressure changes, or if there's temperature changes? Oh yeah, my nose goes crazy during that time. They're obviously not allergic to temperature changes. They have a component of non-allergic rhinitis also. And so they're basically sensitive to these triggers. And then, have you guys heard of this term, local allergic rhinitis? So this first came out in, as far as I can find, 1975, and there's some research that has been done on this. And from from allergists' perspective, it is something to be recognized. And so, what is allergic rhinitis means is that when you're trying to differentiate allergic rhinitis and non-allergic rhinitis, and you skin test them and you blood test them, and they're negative, and you think, okay, they don't have allergic rhinitis, and the patient says, but no, every time I get close to a cat, my nose goes crazy. I don't understand. You're lying to me. And so they took some patients with non-allergic rhinitis, and they tried to detect specific IgE from the nasal secretions, and they're able to find specific IgE to, for example, cat. And then they took these patients and put them under what's called nasal provocation testing, meaning there's a placebo and then there's the allergen, and you try to see if the trigger locally can induce allergic symptoms, and it can, and it does correlate with the specific IgE. And so those patients have local allergic rhinitis. And when I learned about this, it really changed my perspective about non-allergic rhinitis, that there are some non-allergic rhinitis patients who swear that that cats, that certain animals are triggers, and they're not lying. What can we do about this? Really nothing for now, because the testing for specific IgE from the nasal secretions is only done in specialized research centers, also the nasal provocation test. And so it's really labor intensive and time consuming to do this. And so right now we just kind of accept that. We're not doing much with them. There are some allergists that I know that they have patients who have that are really difficult to control, and they empirically just put them blindly on a lot of allergens in the allergy shots, and he swears that it does work, but I think without a randomized placebo-controlled trial, it's not going to be universally implemented. And so, I told you about this paper from 1975, but since then there's a lot of papers on this as well. So there's a pretty good paper from 2012 that talks about this condition, if you guys are interested in this. And so the major allergens in worldwide, and definitely in the U.S., are I usually like to split them between indoor and outdoor allergens. So on the bottom, you'll see the indoor allergens. So dust mite, animals, flour, latex, and what I really focuses on is what we routinely skin test to, which is dust mite, cat, dog. We can add other animals like horses, birds, and we also test for cockroach and molds. In terms of the outdoor allergens, there's really three. It's all pollens. It's tree pollens, grass pollens, and weed pollens. In California, or in the Bay Area, we don't have that much weed pollen. So when you hear about ragweed allergies, we don't really have that much there. But we do ask our patients if they travel a lot. If they go to the East Coast a lot and they do get exposed to ragweed a lot, then we do put that in our allergy shots. So here's the panel that we test downstairs in the allergy clinic, and it's basically what I said: a panel of tree pollens, grass pollens, a panel of weed pollens, and then the indoor allergens as well. And so you might have some patients in your clinic that are hesitant to go see an allergist for whatever reason, or they're waiting for their appointment and it's 5 months away, and you're trying to help them and you don't kind of know what to do and you're just waiting for this. One thing you can do is before you bring your patients to the OR, a lot of times you guys get blood tests, or if there's any other reason that you guys get blood testing, you could get the ACHU panel, which tests for a small panel of the indoor and outdoor allergens. So that gives you a pretty good idea about whether a patient has allergic rhinitis or not.
So we just type that into Epic orders, ACHU?
Mm-hmm, ACHU.
Okay.
Or you can put, if you want to be really professional, you can put airborne allergy screen.
I'll remember ACHU.
And just because Jen asked me to talk about the latest diagnostics and treatments as well, I just wanted you to be aware that there's also a microarray that came out, and not a lot of community allergists are using this, but our clinic has been using this more for food allergy, but also my program director has been sending this for aero allergens as well. And he has a good concept. The eyesight panel, this microarray, is done by Thermo Scientific. And so what happens in allergic rhinitis is you make these specific IgE, and it binds to the grass pollen protein, for example. But there are different parts of the grass pollen that it can bind to. And so these are the different parts of the allergen that it's binding to. And certain parts of the allergen are more inducing of allergies than others. And so, for example, dust mite. The major allergen for that we know is DIR-F1, DIR-F2, DIR-P1, DIR-P2. And so there's also other allergens, there's also other epitopes on the aero allergen for dust mites, such as tropomyosin, which cross-reacts with shrimp. And so if you have a patient who comes in and he has a shrimp allergy and he has allergic rhinitis also, and you test for just dust mites, they will be positive. But actually, we don't really know if it's from the shrimp allergy or the dust mite allergy. If you obtain this panel, you will be able to see that it's the tropomyosin. And so in that case, when we see that, we may not recommend dust mite control measures. We might not put the dust mites in the allergy shot, because dust mite takes up half of the allergy shot itself. So if we take that out, it gives us room to put other allergens in there. So instead of the patient getting 3 shots, they get 2 or 1, for example. Like I said, not a lot of community allergists are using this, but I think we will, over time, move to using this more and more, so you might see this. And so with that, we have gone through about half of our learning objectives so far, and so we'll move on to treatment options. And so the first step for treatment of allergic rhinitis is that we would recommend avoidance of triggers. So that's my control measures. If your patient's home looks something like the top right, then you might recommend having them hire a professional to try to clean out the molds in their house. Same as cockroach on the bottom left. We recommend that the patients get rid of their pets also. If they're tested positive, cat really causes a lot of problems, more than dogs, I think, in general. And for outdoor allergens, it's really difficult to avoid them just because pollen, like I said, travels miles and miles and miles away. Even if you cut your front lawn, it doesn't matter because it's the grass pollen that's coming on top of the mountain that's being blown down here that they're getting exposed to. So what we recommend for patients who have outdoor allergen sensitization is there are pollen counts that patients can look up on the internet. And Ted Chu, one of our community allergists, actually does pollen counts every Saturday, and he publishes on the Academy website, and so patients can go on there. And if they see that if they're allergic to grass pollen and it's May and they check the website and grass pollen is really high, then maybe they should do something indoors. Close the windows, stay indoors as much as possible. In terms of medication wise, you guys know sinus rinses very well, so I won't spend too much time on that. And you probably know that intranasal corticosteroid is the most effective pharmacotherapy for allergic rhinitis. One thing that I should mention is what I talked about with Jane is that I've had patients who come to me, mostly pediatric I would say, they come to me and they have been on steroids and they swear that it's not effective at all and they're getting sore throat and they're not feeling good. And I tell them, let's just change one thing at a time. Let's have you do the spray correctly and I'll show you guys how to do that correctly. And they do that for a month, they come back and their symptoms are completely resolved. And so doing the intranasal corticosteroid spray in the correct technique really does work a lot better. And I usually have my patients also go on oral antihistamine as well. Studies have shown that adding oral antihistamine on top of intranasal steroid has not had an additive therapeutic effect for allergic rhinitis. But I still do it anyways. And the reason why I do this is because for asthma, there are studies that show that for steroid inhalers is more effective than Montelukast. We know that for a fact. But if you do a practical study where you send patients out with the two medications, the end outcome is that they're about the same. And the reason is because patients tend to be more adherent to oral medications, so they're taking the Montelukast more often than the inhaler. And so when I send patients on a spray, I don't know if they're going to be adherent to it, so I just kind of give them both to give the benefit of the doubt that I'm trying to maximize my treatment. The next step that I usually go to is azelastine, or one of the intranasal antihistamine. And there is an additive benefit for adding intranasal histamine to intranasal steroid. And then, after doing all of this, if the patients come to me and they're still not well controlled, at that point I usually recommend starting allergy shot. There are some patients who are hesitant, and I basically give them the last treatment. I say, I don't think it's going to help you that much, but we can give it a last shot because you want to avoid injections, you want to avoid surgery, and so I move to Montelukast. There are some patients who do feel a little bit better, but not that much, I would say. And so in terms of the use of the intranasal spray, I went on Google Image and tried to look up instructions for patients to figure out how to use intranasal spray. And I couldn't find one single picture that actually did it the correct way. And this picture came from the American Society of Health System Pharmacists, and they're not doing it correctly. And so I would not depend on websites or pharmacists or other physicians to teach patients how to use the intranasal spray correctly. If you guys have the time, really spend that 2 minutes and teach them how to do it. And like I said, I've had patients who had completely recovery just from doing it from incorrectly to correctly. So we'll toss that out, and we'll do it the right way. So the reason why that was not the correct technique of using the spray is because when you're pointing it upwards, what happens is you're not getting most of the nasal cavity, and so most of the medication is actually going up on the top and kind of bouncing back to the throat, and so they have a lot of throat irritation. But if you angle it towards this way, then you're catching a lot of the nasal cavity where a lot of the inflammation is occurring. And so the way to do that is what we tell patients: nose to toes. They should look down, point the spray upwards, and spray it that way. The other incorrect depiction in the other picture is that she was pointing it towards the septum, and so the most common side effect of intranasal spray is that patients get nose bleeding, and it's probably because they're doing it incorrectly. As you all know, the blood vessels in the nose are mostly in the septum, and most of the inflammation is happening at the turbinates. So if they just point it outwards, then they're basically doing the right way. And I have a spray here. I can demonstrate it to you guys. So basically, just look down, and you could use the other hand and point this way, and easy, right? Yeah, so that took 10 seconds to show patients how to do it.
So are they supposed to irrigate with the saline first, blow their nose and all that stuff, right?
Mm-hmm.
Okay, and then put that in.
Mm-hmm. Yeah, because if you apply the medication first and then you do the rinses, you might wash out some of the medication. And so I mentioned allergy shots. How does allergy shot work? Well, basically we're desensitizing them subcutaneously, and there's this method and sublingual as well. And so I'll talk about the subcutaneous first. And we're introducing the allergen in small amounts. Nobody really understands or knows the molecular mechanism of how this really works. There are some theories on how it works, but allergy shots has been done for over 100 years, so we know that it works and it's getting better. And so there's an escalation phase where we incrementally increase the amount of allergen that is injected into their subcutaneous tissue, usually on the arms. And they come in once a week, and we do this for about 6 to 8 months or so, depending on how often they're attending our clinic, whether they have reactions, and we might need to slow down or back down. But in general, we tell patients 6 to 8 months. If they are encouraged to want to do it to reach maintenance even faster, they can come to our clinic twice a week and reach the maintenance phase in 3 to 4 months. And so when they reach the maintenance, they come to get shots just once a month. They stay in our clinic and they get observed for 30 minutes, and that's really it. When they're on maintenance, we recommend doing it for at least 3 years and probably 5 years. And the reason for that is because allergy shots is the only known treatment to cure allergies. All the pharmacotherapies, they suppress the symptoms. Once they go off of it, symptoms come back. But allergen immunotherapy actually changes the natural progression of the disease, so that after 3 to 5 years, if you take them off of the allergy shots, they are, some of them are basically cured. And so my program director likes to simplify it to patients and say, after 3 years, reevaluate the situation. If you go off the shots, you will have 50% or about half of the chance that you won't have allergic rhinitis anymore. All of you will improve, but if you go off, about half of them, you will not have any more symptoms for at least a couple of years. And but you can choose to continue continuing. And some patients stay on allergy shots for life. And for the patients who decide to come off, we tell them you can try that, and if you ever want to go back on shots, we can do that for you. You just basically have to go through the escalation phase again. But other than that, you can always go back on it.
I have a question.
Yeah.
I have a lot of patients that had shots maybe more than 10 years ago. They kind of say, well, maybe help a little bit, but now we still have a question about persistent allergy. Would you expect new allergens to develop in the interval, or do you think they're just a non-responder? Or would you consider giving that person another try at immunotherapy?
Yeah, that's a good question. We get that question a lot also from patients as well. I think there's a couple of questions there or issues there. One is that we don't know after 10 years what is the effect. Like I said, the studies have only been done for about 3, maybe 7 years after after immunotherapy. And for 10 years, 20 years, nobody really knows at that time frame. And so, there's other issues. For example, allergy shots have improved since 30 years ago. So there are patients who say, 30 years ago I was on allergy shots and it didn't do that much for me. The way that it's extracted, the way that it's manufactured by the company, and the way that it's created, there are some extracts that are actually, they spike it with major allergen to make it, to increase the potency, and they've been doing it for the past 10, 20 years or so. And so allergy shots itself is improving. And the third thing that I tell patients is that we know that allergy shots is quote unquote a cure for allergic rhinitis, but it can come back. So for example, if someone has a broken leg and US surgeons fix that broken leg, it's cured, right? But it doesn't mean that 10 years from now they might not have an accident and break it again, and so they might need to have another surgery. And so if a patient has new allergies again, then I would put them back on allergy shots. So I think it's very possible that their previous allergy was improved or even cured from allergy shots, and they just have the disease come back or new sensitization. Does that kind of answer?
But I mean, just to know, how common is new sensitization at middle age or beyond? I mean, I always think of the immune system kind of on the decline in older patients, and yet we saw patients who maybe had negative testing at the age of in their 30s and then they're 60, and you question whether there are new allergies present, but how often does that actually happen, and what's the mechanism for that if you assume that they had no new exposures necessarily to their environment, they haven't moved, they haven't had a job change?
Yeah, that's a good point. I think it's pretty rare that for the 60 years old that they have new sensitization. So I think for that situation, probably either the allergy shot in the past was not effective based on the way that it was manufactured, or the way that the allergists have actually created the allergy shot, because we know that not all allergists make the allergy shot the same way. I was just looking through the binder in our allergy clinic the other day, and I've noticed that different people do their allergy shots in different ways. And I'll talk a little bit about that. So that might be one reason. So I would, by that point, I would have an allergist that you really trust do a second evaluation or opinion to see whether we can try to really create a good allergy shot for that patient.
How valuable is it to do a total IgE first before you ever plan to put the patients on desensitization? Is that something that's commonly done by you?
What do you mean? Can you?
Getting a serum total IgE, and if they're more than 100, they are probably atopic. If they're less, or whatever the value is, would that predict their allergenicity?
The total IgE, we don't find it that helpful. That's more based on studies on the risk factors for developing allergies. So for example, when researchers are trying to find what are the risk factors, they look at children who are really young, and they try to get total IgE to see if it's atopy that's associated with it. But other than that, it doesn't really help us in terms of really determining if someone has allergies or not, or how we come up with our allergy shot. Because we can just get the specific IgE, and it's really easy to do that. And that's much more specific than the total IgE. That's much more helpful. And so just continuing to answer Dr. Wong's question, we do have a practice parameter on from our organization on their recommendation on how to implement allergy shots. And so there are tables on what are the effective dose of the allergy shot, as you can see in the table. So for dust mite, it's 500 to 2,000 AU. And this table really came from research studies for the past 10, 20, 30 years. Gradually, we're learning more and more about this. So like I said, it's possible that 30, 40 years ago, when your patient was on allergy shot, this data was not very widespread, it's not very available, and but now we have these recommendations to really help us increase the effectiveness of allergy shots. And with that, I have to say that it's possible that not all allergists follow this parameter. They may be in practice for 30 years, and they have their way of doing things, and so you might run into that. Sublingual immunotherapy, this is really used in Europe, not really in the US. But it does work a little bit. So Europeans can do it, kids can do it, dogs can do it. But there are some issues with sublingual immunotherapy. And the issue is that there are meta-analysis studies that show that there hasn't been a large-scale head-to-head trial between allergy shot and sublingual immunotherapy. But when they try to just make some general comparisons, what has been found is that allergy shot is generally more effective than sublingual immunotherapy. So this is a meta-analysis that talked about that. And Hal Nelson, which is one of the prominent researchers on allergy shot, he also agreed very recently in 2014 that allergy shots is more effective than sublingual. And so any patient who's interested in this, I usually mention that to them so they know about that. And that is because sublingual immunotherapy tablets have recently come out. And there are two allergens. There's grass pollen and there's ragweed. You can kind of ignore the bottom, like I said, because we're not in the East Coast. For grass pollen, they're the tablets. I honestly, for the year and a half that it has come on the market, I have not used it on a single patient. And that is because most of our patients here are not monosensitized to grass pollen. They're allergic to many, many different things, and just putting them on grass pollen, it's not going to help them that much. My program director had a few patients who had whopping large skin tests to grass and very small and everything else, and so he has tried to prescribe this to his patients, and he's run into problems. Number one, certain pharmacies, they don't carry it. Number two, insurance companies are calling him back and say, allergy shots are cheaper than these tablets. Can you do allergy shots instead? So there are some issues with this. The benefit of this is that we do have patients, for example, coming from Central California, and they're Medi-Cal or some other insurance that local allergists they don't recognize, they don't see these patients. So we can't do allergy shots for them because they have to drive 3 hours to come see us. So we do try to do sublingual immunotherapy for them. And just so you know, dust mite sublingual immunotherapy will probably be coming out in the US in the next year or two, is my prediction. It has already been approved 2 months ago in Europe and a month ago in Japan. I reviewed the papers for this. It decreases allergic asthma, allergic rhinitis. It is effective. I would have to say that I have more patients who are monosensitized to dust mite, much more so than grass pollen, so I think this might be something that could be useful. In Asia, it's definitely useful. Pollens are a little bit lower there, and there's just a lot of dust mite. because of the humidity in that part of the world. Any of you know Xolair omalizumab? So this is anti-IgE. It's a subcutaneous shot every 2 weeks or every 4 weeks. And so I reviewed to see if this is effective for allergic rhinitis. And the first paper that I was able to find is one from JAMA in 2001. And they had a pretty good study, 536 patients. And they basically were able to conclude that Xolair omalizumab was effective in treating allergic rhinitis. Since then, there are other studies that have basically said the same exact, had made the same exact conclusion, meta-analysis as well, and review papers have also supported the use of omalizumab for allergic rhinitis. So, in that, I started wondering this. Our practice parameters from 2008 said omalizumab has demonstrated efficacy in allergic rhinitis. However, it has FDA approval for use only in allergic asthma, and recently also in chronic urticaria, but not allergic rhinitis. So I don't really understand why FDA has not approved it based on the overwhelming evidence that it does work. But I did find this paper, and their opinion is that on the bottom it says omalizumab may provide a new treatment strategy for allergic rhinitis, but the high cost of omalizumab precludes its chronic use for allergic rhinitis and is not FDA approved for this indication. So my guess is cost might be an issue, I don't know. However, its periodic use may be justified in treatment-resistant patients, especially those with seasonal disease. So I would say that if you have a patient who has severe allergic rhinitis, you've done all the pharmacotherapy, they did allergy shots, they've done surgery, and they're still having this issue, ask them, do you have asthma? How bad is it? Because if they have moderate to severe asthma and they're not on omalizumab, you can call their pulmonologist or allergist and say, can this patient go on omalizumab for asthma, which would also treat their allergic rhinitis as well. So that would be one strategy of approaching that. Lastly, just kind of to go over some medications that might be coming on in the far future, I would say. We know that allergic rhinitis is a Th2 driven inflammation, and so what that means basically is that there is the T cell, they don't know what to do. They need to tell the B cell to do something when there's antigen that comes into the body, and so the B cells can make IgG, it can make IgA, or it can make IgE. And so the T cells know what to do when they receive signals to tell it to become a naive T helper cell into a Th2. And that signal is driven by a lot of cytokines, but one major one is IL-4. And IL-4 tells the T cell to become Th2, then Th2 then secretes IL-4 and IL-13 to tell the B cells to make IgE. IgE then binds to the mast cell, and then the next time that the patient is exposed to allergen, there's mast cell degranulation of histamine, vasoactive peptides, neuroactive peptides, and that causes a lot of problems for patients. And so IL-4 and IL-13 is something that is very implicated in this pathway. IL-5 as well, that comes from Th2 T helper 2 cells, and that induces the activation and proliferation of eosinophils. And so with that, there are monoclonal antibodies that have been created to try to block these pathways. Lebrikizumab is an anti-IL-13, and it's really been proven for asthma. Dupilumab is anti-IL-4 and anti-IL-13, and it's been proven to be helpful for asthma and atopic dermatitis. And then mepolizumab is an anti-IL-5 that's been proven to be helpful in eosinophilic asthma and hyper-eosinophilic syndrome. I think the fact that FDA has still not approved omalizumab for allergic rhinitis, it'll probably take them even a longer time to approve these biologics, given it's still really in the research phase. But I think this is something that you might hear more about in the future. And so with that, we've gone through all the learning objectives. Any questions or? Yeah.
I have two questions about food allergies. Serum testing in the past is pretty unreliable in terms of sensitivity. How much better is the microarray in terms of sensitivity?
So
for food allergies?
people are looking into that. There's a lot of research that's going into that. We call it component resolved diagnostics. So if you search for that, you'll see a lot of papers on that. So there's going to be more and more data about it. For now, our clinic is using the components, the microarray, to predict whether someone actually does have either food allergy or ongoing food allergy. The food that has the most research done is peanut, and we know that RH2 is strongly associated with actual food allergy, but RH8 is not. And the reason why we think that's the case is, have you guys heard of something called oral allergy syndrome, which is somewhat related to this, also called pollen food allergy syndrome. And so for those patients, they have allergic rhinitis. They have IgE that binds to birch pollen or other tree grass pollens, and they are cross-reactive with certain foods, especially those that derive from plants and fruits. And peanut is kind of plant related, and so RH8, one of the components, is actually related to the birch pollen. And so when patients have allergic rhinitis, they eat peanut, they might have some itchy mouth, or maybe even nothing at all. So for example, when a teenager comes to our clinic and they had a past history of peanut allergy, but they also have allergic rhinitis, we do serum or skin testing to peanut. They're positive, but we don't know if it's RH2, which is the food allergy one, or the RH8, which is the oral allergy syndrome one. We do the components, and if they are RH8, then we do a food challenge to see if they actually did outgrow the peanut allergy, and some of them do. So it's been helpful for us.
And then my second question is, you mentioned that your mentor was talking about rhinologists versus a rhinologic surgeon. Do you think allergists are interested in treating non-allergic rhinitis? Because I feel like in my community practice before my current job, basically we send them to an allergist, and if their skin testing was negative, they got booted back to our clinic so fast, like the patient's head was spinning, and we were treating their non-allergic rhinitis, which is fine. But I was wondering, is there a movement in your community to sort of become more holistic for all causes of rhinitis and treat it?
That's a really good question. I talked to Jane about that question. Actually, she had the same exact question. And so we are interested in treating non-allergic rhinitis. Actually, if we have a referral from a primary physician for a patient being evaluated for rhinitis, and they are not followed by ENT, and we see them and they're tested negative for allergies, we take on the role of taking care of their non-allergic rhinitis. The thing about when ENT refers patients to us, you guys are so good at taking care of rhinitis that we don't think that we have any additional input other than having many cooks in the kitchen. If two specialists are changing medications, it might confuse the patient. And so the way that I explained to Jane is that the way that we see rhinitis is allergic and non-allergic. That's how allergists sees it. But patients don't see it that way because they're exposed to perfume, and that triggers their symptom, and they think, I'm allergic to perfume. That's how they view their problem. And so I don't undermine that. I tell them that, I explain to them, to us, the only big difference between allergic and non-allergic rhinitis is we can do shots for you for allergic rhinitis. We cannot do shots for you for non-allergic rhinitis. But I also emphasize to them, I know that this is a problem for you, you have triggers, and you're sensitive to these triggers. And so the good news is there are some medications that can help you. And so we can help you with that. But because ENT are so good at dealing with that, I think it's better if you go back and allow your ENT doctors to really take care of this problem. But I think that not all allergists take the time to really explain that to patients when they're seeing 100 patients a day, and so they say, well, you don't have allergic rhinitis, you have non-allergic rhinitis, so you should just go back to your ENT doc. And so they feel pretty frustrated, thinking that, you know, I'm allergic to perfume without getting a pretty clear explanation about that. But I would say that a lot of my attendings basically do the same thing. If it's a referral from ENT and they have non-allergic rhinitis, we just defer to allow you guys to take care of it so that we don't confuse the picture.
I think there's some confusion on our patients between food sensitivity and food allergy. Most of our patients, they know what foods they're allergic to. They have an immediate IgE reaction. But when the allergist does food testing, you do IgE testing, you're not doing IgG or anything in the way of sensitivity testing. So other than withdrawal and challenge, what else do you recommend for patients who may be food sensitive but not food allergic?
Yeah, so when patients come to us for food allergy, we also have the same classification that I showed you for rhinitis, but in a different way. And so there is the IgE-mediated type 1 immediate type hypersensitivity for food allergy, where they can develop anaphylaxis. So that's one category. But then there's all these other categories, such as celiac disease, such as lactose intolerance, such as eosinophilic esophagitis. So we really try to, when the patient comes in, it's really based on history. When you ate that food, what happened? Did you have hives, or did you vomit, or did you start eating wheat and have diarrhea? And kind of that drives us to determine what kind of testing and what kind of approach we have.
What specific objective testing would you do for foods that is reliable for you?
In terms of the food allergy.
Objective testing, yeah.
Usually what we do when a patient comes to us for food allergy is that we either do a skin test or a blood test for a specific IgE. With that, when it's negative, it's very good. More than 90% of the negative predictive value for specific IgE to foods is 90%. So if someone is skin test positive and blood test skin test negative and blood test negative, then we have a real high confidence that this patient does not have a food allergy. And so, but if there's a convincing history that I ate that food and I really had a really severe allergic reaction, then with the very reliable test, we'll say, let's do a food challenge. And so we'll give them food little by little, not in a desensitized way, but kind of a higher level than that, to try to see if we can elicit any symptoms. And usually when they have negative testing, they pass and they don't have any problems. So either they don't have the food allergy and it was something else, or they outgrew their food allergy. When it's positive, 50% of the time is a false positive. So it really depends on the situation. Patients who have eczema have a lot of non-specific IgE that is not doing anything. It's noise. It's just there. And those are one of the more challenging situations for us as allergists. And I don't have a really easy answer for that. But if by history it sounds like it is a true food allergy, we'll say to continue avoiding it, and hopefully your specific IgE will come down through time. And when it becomes really low or negative, we can do a challenge at that time. If the history is not very convincing, we might do a challenge even if the specific IgE is positive.
Thank you very much.
Hey Jamie, it was great having you in my clinic and everything. So always, you and I, the fellows, always welcome. Quick 3 questions. Do you guys consider topical nasal steroids any differently between them? The Flonase versus Nasonex versus any of the others? We think of them as kind of equivalent. We just go with people's patients' insurance. Is that it is in your community as well?
The practice parameter said that between the intranasal corticosteroid and the oral antihistamine, there's no difference between them. So that's what the practice parameters say. Some people swear that for whatever reason, Flonase works better than Nasacort. You might have heard of that too.
Right.
I don't know.
It's not something that is. It's not like if you have a gradation, like if you fail that. In the allergy world, it's not something that's you keep stepping up to, Omnaris or something.
Mm-hmm. It really depends on the allergist. Different allergists have different styles. There's no strong data to support any of this. I would say a lot of allergists in general, if one spray doesn't work very well, they might switch to something else. And it's really the side effects of things. I find that Nasacort is a little bit more mild. But if they don't like the spray and if they don't like the squirt, but they like the spray, we might change it to that.
So that's both things. You didn't mention anything about topical budesonide or intranasal injections of steroids. Any current recommendations or thoughts on that in the allergy world?
Topical budesonide versus what was it?
And also injections of steroids into the turbinates, for example. Is that at all favored or out of vogue like it is in the ENT world? Or?
Yeah, I didn't see any comparisons of intranasal steroid even with budesonide rinses. But I have a lot of patients who swear, and a lot of allergists, and probably you guys swear that the budesonide rinses is more effective than nasal steroid. So that's something that is probably under the anecdotal experience that there's not strong data on it, but again, the practice parameters, some recommendations, even the definition of rhinitis is D. And so I think this is one of those things where it's based on our experience that budesonide rinses is probably more effective. In terms of the steroid injections, I haven't looked into that, but I will. But you guys probably know this better than I do since you guys go in there more and inject medications.
There's rare scary reports of blindness and things like that.
In Fremont, when the ear, nose, and throat specialist got blindness from injecting the patient.
So these scary scattered reports.
Do you find it helpful or effective in terms?
Rarely have done it, only for the really last line, failed everything. Offer them, make sure they sign consent situation, maybe twice in 7 years.
But if you're going to do that, it's wise to pre-inject with epinephrine.
Yeah.
To get vasoconstriction.
Absolutely, yeah. But I know of one for sure, and I remember the patient, it's not anecdotal, she's blind in one eye.
Well, I've always say to students that there's always a urologist and a nephrologist, a cardiac surgeon, a cardiologist, etc. Never have I heard there's a medical otolaryngologist or a medical rhinologist. I love it. We're now a surgical field officially.
It really changed the way I think of rhinitis.
I think, all joking aside, that the integrated care model as represented by our rhinology clinic, really, which was Peter's vision in building a single point of care where you can see an allergist, a surgical rhinologist, have your CT scan, have your allergic therapy, have your aspirin desensitization, all done in one location is extraordinarily good model for medical care. And I really compliment how well that's been put together.
And we have a really good interaction with you guys just because we come rotate here. Tomorrow I'm going to be in clinic, downstairs, and we'll be interacting together. So I think it's great. And I didn't go over this because you guys are the experts of this, but our practice parameter did talk about the benefits of surgery for allergic rhinitis. So in our field, we also recognize how beneficial it is as well. So you will get referrals from us for patients who have allergic rhinitis and septal deviation or turbinate hypertrophy or adenoid hypertrophy. We'll definitely refer them to you.
Man, it's a different one.
Thank you.